Thank you very much for your kind introduction. As we all know, patients with chronic kidney disease present extremely high cardiovascular risk, and there are many risk factors that are responsible for these associations, including both traditional and non-traditional ones. Among the traditional ones, male sex is considered to play a significant role. In a recent study, in almost 900 patients with hypertension and pre-dialysis chronic kidney disease, aiming to examine the differences in office and ambulatory blood pressure levels between men and women and their association with hard outcomes, it has been demonstrated that there are no differences in office blood pressure levels between men and women. But male participants were found to have significantly higher blood pressure levels during the whole 24-hour period, also in the separate day and nighttime interval. And these differences in ambulatory blood pressure control was found to be the main determinants associated with poor prognosis of men versus women. In particular, as you can see in Model 1, men had higher risk for death and progression to end-stage kidney disease compared to women. After adjusting for office blood pressure, as we can see in Model 2, these associations did not change. While in Model 3, after the adjustment for ambulatory blood pressure at goal, the increased risk for end-stage kidney disease and death attenuated, suggesting that worse ambulatory blood pressure control is a major factor contributing to increased cardiovascular risk of men versus women. With regards to end-stage kidney disease, a recent work from our group showed that men had higher ambulatory blood pressure during the 48-hour period than women. But we don't know if these higher levels of blood pressure had a significant effect on the association of sex with cardiovascular events and mortality in this population. So we designed this study in order to investigate the influence of ambulatory blood pressure on the associations of sex with cardiovascular events and mortality in hemodialysis individuals. This is a prospective cohort study that included 220 patients on hemodialysis, 129 males and 91 female, with a mean follow-up of approximately 55 months. All patients underwent 48 ambulatory blood pressure monitoring with mobilograph device, and the primary endpoint was cardiovascular mortality. As for the secondary endpoint was cardiovascular death, non-fatal myocardial infarction, non-fatal stroke, resuscitation after cardiac arrest, hospitalization for heart failure, coronary or peripheral revascularization procedure. For the examination, the association of sex with adverse outcomes, we performed Kaplan-Meier survivor analysis in order to assess the cumulative freedom from the primary and secondary endpoints in men and women, and also uni and multivariate Cox recognition analysis, and we calculated the crude and adjusted hazard ratio for both the primary and secondary endpoints. We used men as a reference group, and we included two different adjusted models. Model 1 after adjustment of age, dialysis, vintage, diabetes, and coronary heart disease. And Model 2, we adjusted for these variables and 44-hour systolic blood pressure. Here you can see the baseline characteristics of our cohort. This is a typical hemodialysis population with mean age of 64 years. No significant differences between male and female in age, dialysis, vintage, BMI, and the prevalence of major comorbidities were detected. As for blood pressure levels, men presented with higher 48-hour systolic and diastolic blood pressure levels, but no differences in antihypertensive medication. The cumulative freedom for the primary endpoint was higher in women, which means women had higher risk for cardiovascular mortality, and this leads to a higher crude hazard ratio to 1.61. However, this association attenuated after adjustment for the traditional risk factors in Model 1, and the addition of 24-hour systolic blood pressure in the model did not change these associations. Similar were the findings for the secondary endpoint. You can see here there was no differences in the cumulative freedom from the composite cardiovascular risk endpoint among men and women, and this association did not change after adjustment for rational risk factors and for 44-hour systolic blood pressure. Before closing, we should mention some strengths and limitations. The first study investigated the influence of ambulatory blood pressure on the association of sex with cardiovascular events and mortality in hemodialysis individuals. We used 48 ambulatory blood pressure monitoring, which is a very difficult task to do in hemodialysis patients, and our study include a large sample, more than 220 participants, and one of the largest follow-up in the literature with 48-hour ambulatory blood pressure monitoring, reaching up to 5 years. Among the main limitations, we performed ambulatory blood pressure monitoring only once at baseline evaluation, so we cannot be sure whether changes in blood pressure control over time existed and whether they influenced the observed results. Finally, the totality of our patients were of Caucasian race, so our findings should be applied with caution in other populations. Our conclusion were ambulatory blood pressure levels are higher in male than female hemodialysis patients. In contrast to patients with pre-dialysis chronic kidney disease, ambulatory blood pressure does not appear to significantly influence the relationship between sex and adverse cardiovascular outcomes in hemodialysis patients. And last but not least, cardiovascular mortality is extremely high in patients with end-stage kidney disease and is affected by both general and chronic kidney disease-related risk factors. And consequently, there is no protection associated with the presence of female sex. Thank you very much for your attention.